This podcast is being recorded on the land of the Bunurong people of the Kulin Nation. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
This podcast is not sponsored by any pharmaceutical companies. We aim to provide balanced, evidence-based discussion without commercial influence, and wherever possible we refer to medications by their generic names. We acknowledge the value of any new methods of contraception, noting that the availability of these medications may differ between Australia and Aotearoa, New Zealand. Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at the latest RANZCOG guidelines and RANZCOG research through in-depth conversations with leading experts in obstetrics and gynaecology. I'm Dr. Heather Waterfall. I'm an obstetrician and gynaecologist based in South Australia, where I'm chair of the South Australian Northern Territory State Committee.
And I'm Dr. Nisha Khot. I'm an obstetrician based in Melbourne, and I'm the head of the O&G department at Peninsula Health. I'm also RANZCOG's president-elect. Heather and I are together your hosts today. In this episode, we'll be diving into RANZCOG's updated clinical guideline on contraception. The guideline is packed with clear evidence-based advice for every life stage from adolescence to menopause. We'll break down what's new, what's most important for clinicians, and how we can deliver contraceptive care that is safe, effective, and centered on the needs of patients.
Joining us are two experts in contraceptive care who played key roles in shaping this updated guideline. First, we have Professor Kirsten Black, an academic gynaecologist from the University of Sydney. Welcome.
Thank you for having me.
Kirsten is the chair of RANZCOG's Sexual and Reproductive Health Special Interest Group, and she also led the development of this guideline as the chair of the Guideline Development Group. Also with us is Dr. Catriona Melville, a specialist gynaecologist and sexual reproductive health subspecialist. Catriona sits on the Council of the UK's Faculty of Sexual and Reproductive Healthcare, the body behind the original guideline that RANZCOG's new contraceptive guideline is adapted from. She also contributed directly to RANZCOG's Guideline Development Group, helping to tailor it for clinical practice in Australia and New Zealand.
Thanks for having me.
Welcome to you both. Before we start talking, I wanted to remind all of our listeners that if they are a user of contraception, remember, always speak to your own doctor before starting any contraception. And also, before we begin, I'd like to invite our guests to declare any relevant conflicts of interest, including any affiliations to pharmaceutical companies, industry bodies, or any organisations that we might reference in this episode. Catriona.
Yes, so as you mentioned, I sit on the UK Council of the Faculty of Sexual and Reproductive Health as the international representative, and I have also participated in the Policy Consensus Implant Training Recommendations meeting, which is sponsored by Organon.
Thanks. Kirsten.
And I sit on the United Kingdom's medical eligibility criteria for contraception use. They're currently in the process of updating those guidelines, and I am also an international expert on that group.
Thank you both.
Kirsten, let's start by talking about the development of this guideline. What drove this revision and what existed before? How is this different?
So previously we had a range of statements on contraception and they needed to be updated, and the Guideline Development Group worked with the Faculty of Sexual and Reproductive Health in the United Kingdom to adapt their excellent clinical guidelines to the Australian and Aotearoa, New Zealand context.
Thanks, Kirsten. Catriona, can you talk us through what the new contraception guideline says about counselling and how this should be tailored throughout the different stages of life?
Yeah, thanks, Nisha. So I think to start off with, it's really important to know that there's not really any method of contraception that's precluded use is by age alone. So often we hear some myths about young people, for example, not being able to use certain methods of contraception such as IUDs, and that's simply not true. To focus, I suppose, to start with on young people, it's really important that when you have a consultation with a young person and you're counselling them regarding contraception, that you do have a safety framework in terms of assessing capacity, consent and competence at every visit. And you can use something like the Fraser Guidelines just to give yourself a framework. You should also make sure the young person is aware of their confidentiality guidelines and that you won't breach their confidentiality, for example, unless you have got child protection concerns. And you should do a risk assessment at every visit just to ensure that that young person is not subject to any reproductive coercion or any other kind of grooming or controlling behaviour. I think with anyone seeking contraception, it's really important to emphasise the benefits of the long-acting reversible contraceptive methods, and especially that they're very effective. So again, this would apply to young people, but people at all ages, and also to spend some time exploring some of the myths about contraception and explaining the benefits. For example, that if you're a teenager and you've perhaps got some problems with your skin, that combined oral contraception can help that. When I mentioned that contraceptives are not solely contraindicated by age, there's just one caveat, and that would be using Depo-Provera, depomedroxyprogesterone acetate, in young adolescents who haven't reached full bone maturity, just because we know there's that slight decrease in bone density during use, which recovers after use. So that wouldn't usually be used first line in somebody under 18. It could be considered if other methods aren't suitable. So then moving to the sort of other end of the reproductive spectrum, so women over 40, that's quite an interesting area with contraception. There's a lot of contraceptive methods at that age that do have these kind of dual benefits. So it's not uncommon to develop heavy menstrual bleeding in your 40s and also maybe some perimenopausal symptoms. So something like the combined oral contraceptive pill can be used and can benefit those symptoms. And also your levonorgestrel IUD, so something like the Mirena, is also very effective for helping with heavy periods and can be used right up to the age of 55 when most women no longer need contraception. The caveat to that is that if you're using the IUD for protection of the endometrium, that it has to be replaced after 5 years. And generally in older women, we would cease the combined oral contraceptive pill and the Depo-Provera at age 50, just because at that stage the risks would outweigh the benefits. Combined oral contraceptives can be continued to the age of 50 if women don't have other comorbidities, and that's something just to also consider in that age group, that as we age, we do sometimes take on other diseases such as high blood pressure or maybe our weight increases. So those are just other things you would have to think about in that age group. But if people don't have any additional risk, they can safely use combined oral contraception to the age of 50. Sometimes it would be a good thing to consider just reducing that dose of estrogen because some of the risks are estrogen dependent. So I would look at maybe a pill that's less than 30 micrograms in your women that are approaching 50.
Kirsten, what's new in terms of guidance around quick starting different contraceptive methods?
So contraception can be commenced at any time in the menstrual cycle when pregnancy is reasonably excluded. For example, if you have a urine pregnancy test over 21 days since the last unprotected sex, or less than 5 days after an abortion, or during menses, obviously. But quick starting contraception is the initiation of certain methods when pregnancy hasn't fully been excluded. In this circumstance, you can quick start a range of methods, including the combined oral contraceptive pill, the progesterone-only pill, and the implant. It's not so recommended to start the injectable Depo-Provera. And you shouldn't start an IUD unless pregnancy has been excluded. The only caveat being that you may be using the copper IUD for emergency contraception and then you can use it. So in those sort of circumstances, so you can start most methods immediately, even though pregnancy has not entirely been excluded, but important to communicate the need for a urine pregnancy test 21 days after the last unprotected sexual intercourse. The other important thing to advise women is that if you're quick starting a method, then you need to just advise them that they have to take additional precautions until that method becomes effective. And further, if you can't quick start a method, like their preference is for an IUD, then it's best to provide some sort of bridging contraception that is acceptable, such as the progesterone-only pill.
That brings us very nicely to some of the newer progesterone-only pills
Yes.
that have become available in recent times.
Yes.
What are the advantages and what are these pills? What sorts of pills are available?
Yeah, so there's different pills available in Australia and Aotearoa, New Zealand. In Australia, it's drospirenone, 4 milligram tablets, registered under the name of Slinda. And the advantage of this pill and the one available in New Zealand called Cerazette, which is a desogestrel pill, is that they do prevent ovulation. So they're as reliable as the combined oral contraceptive pill without the contraindications of estrogen-containing pills. And the good news is that in Australia, the drospirenone pill now has PBS listing, and in New Zealand, the desogestrel pill has Pharmac listings. So this means it reduces the cost and increasing access to these highly effective and very low-risk methods of contraception.
What else is an advantage in terms of progesterone pills? I remember we used to tell people that they had to be taken at a certain time every single day.
Yeah, so in their mechanism of action in being suppressing ovulation, they don't have the 3-hour window that the other progesterone-only pills have. So they have 24-hour window, and that's a huge advantage. And also just increased efficacy because they're not just relying on the effect of thickening the mucus and thinning the endometrium, they're actually suppressing ovulation.
That's a huge advantage because trying to
Absolutely.
remember to take a pill within a small time frame is tricky.
Absolutely.
Kirsten, can I ask you, talking about the depot injection and how we wouldn't recommend it for adolescents because of bone mineral density, what's your thoughts on the progesterone-only pills and in particular the Slinda and Cerazette for women under 18? Are we worried about estrogen and bone mineral density in that population?
So the Depo-Provera causes very severe suppression of estrogen, whereas there is no evidence that that occurs with oral progesterones nor with the implant. So we can be very confident that they are safe methods to use in adolescents and also safe methods to use, women in the later reproductive years. So I would have no hesitation in providing a progesterone-only pill or implant to adolescents.
Great, thank you for that. That brings us on then to the combined oral contraceptive options and in particular a discussion of the risks and the benefits. Catriona, what should clinicians keep in mind when it comes to the risks of the combined oral contraceptives and what are some of the benefits that we don't look at when we're talking about contraception?
Yeah, thanks, Heather. Well, overall, combined oral contraception is incredibly safe and very effective if it's taken with perfect use. But there obviously are some caveats to that, and it's important, for example, that we don't use it in women who have migraine with aura or women who are smoking over the age of 35. But if we use careful selection of our patients, it is very safe, as I said earlier, up to the age of 50. We do know that there's a small increased risk of venous thromboembolism with combined hormonal contraceptive use. However, the absolute risk is small. And again, comparing it to something like the risk of VTE in pregnancy, it's far, far smaller than that. There is also a very small increased risk of breast cancer when you're actively taking the combined oral contraceptive pill. However, it's a very small risk and it does reduce with time after stopping combined hormonal contraception. And I'm really glad you asked about the benefits because these are really often overlooked with combined hormonal contraception. So, for example, they're great at reducing heavy menstrual bleeding and menstrual pain, including in women who have endometriosis. They can also improve acne, and any pill can improve acne because all the combined contraceptive pills reduce the sex hormone binding globulin, therefore making the androgen profile more favourable and reducing acne. Then they can be good for women who have symptoms of PMS and also can help with some of the symptoms of polycystic ovarian syndrome. In some of these conditions, such as endometriosis, it can also be favourable just to what we used to say, run the active pills together. So omit your pill-free interval and don't take the sugar pills. And in fact, some of the newer contraceptive pills are designed like that, to have many, many days of active pills and only a 4-day pill-free interval. And again, on the topic of cancers, there is an associated reduced risk of ovarian and endometrial cancer for people that have taken combined hormonal contraception. And that reduced risk actually lasts for decades after cessation of the pill. And there's also reduced risk of colorectal cancer. So there are lots and lots of benefits. One thing I would like to mention is we do seem quite fond of using combined oral contraceptive pills in Australia that contain cyproterone acetate. So those would be pills like Diane or Brenda. And they also have 35 micrograms of phenyl estradiol in the pills. And it's important to note that they're not actually primarily licensed as contraceptives. So their primary indication is for treatment of moderate acne. And obviously they do have a contraceptive effect, but they're not the pills that we should be choosing as our first line choice for contraceptive use. We should be using typically a pill that contains an estrogen and a progestogen with 30 micrograms of phenyl estradiol as our first choice, and not a CPA containing pill.
That's really good for our prescribers to think about as well.
Kirsten, we're going to move on to talking about long-acting reversible contraception, specifically the intrauterine devices. We know that IUDs are safe, they are highly effective, yet they are very underutilized in Australia and New Zealand, somewhere around 8% when compared with somewhere like Sweden, where it's 22%. Why is there such a gap in IUD use in our part of the world?
I think there's a range of reasons. Interestingly, recently there's some data released from the National Women's Health Survey, which found that 7 in 10 women, at least across Australia, did not know anything about hormonal IUDs, and 8 out of 10 women didn't know anything about copper IUDs. So we have a huge knowledge gap, and I would hazard a guess that it's similar in New Zealand. And I think knowledge of and myths about potential side effects. There's a lot of publicity about the pain of IUD insertions. I think that we need to therefore have public health awareness increased. Like we need, through schools, increased education, sexual health education around different contraceptive options. But also I think public health messaging needs to improve around what the contraceptive options are. In terms of healthcare practitioners, I think we need greater training and education around the benefits of IUDs, because IUDs, as we know, are not only highly effective, particularly the hormonal IUDs offer a range of non-contraceptive benefits, reducing pain and bleeding with the menses. But in Australia, at least, it's been heartening to see the government respond to requests to improve access to long-acting reversible methods. And some of the ways they're going to plan to tackle that is by increasing the rebate for clinicians, because I think this has been a barrier, so that doctors are paid more for the procedure. I think they are also providing GPs incentives to train, to bulk bill patients firstly, but also more opportunities to train with these LARC training centres that are going to be established. Both in New Zealand and Australia, I think there are there have been cost barriers, and in both countries, women will often fork out several $100s to get an IUD inserted. There are also cultural barriers and misunderstandings are really around, the benefits and risks of IUDs. So I think that we have work to do in a number of different ways, but public education and practitioner education and training, I think, are the most important.
Did you know endometriosis can now be diagnosed with ultrasound or MRI? RANZCOG has released the Australian Living Evidence Guideline, Endometriosis, a fully updated clinical resource which will improve care for people living with endometriosis. Find out what's changed in diagnosis, treatment, and in management. The guideline also includes a summary flowchart highlighting the care and management pathway of people with suspected or diagnosed endometriosis. A quick reference guide has been developed for primary care providers, and there are also new resources available for the public. The Living Evidence Guideline brings together the latest research with clinical expertise and lived experience to ensure care providers have access to reliable and up-to-date information. Explore the new resources on the RANZCOG website. Visit ranzcog.edu.au/endometriosis. Let's talk about contraception after pregnancy. Catriona, what do the guidelines recommend regarding contraception immediately postpartum and after pregnancy?
Yeah, so I think one of the important things is to start discussing contraception and contraceptive needs in the antenatal period, or preferably even preconception, because we know that an interpregnancy interval of less than 12 months is associated with an increased risk of preterm birth and low birth weight and small for gestational age in the subsequent pregnancy. So spacing pregnancies is really critical. With that in mind, both breastfeeding and non-breastfeeding women should initiate contraception as soon as possible after birth. And there's lots of methods that are incredibly safe. Obviously, we do favour the LARC methods because of their efficacy. And we know that, for example, insertion of an IUD immediately after delivery, whether that's a caesarean or a vaginal birth, is completely safe. If you don't initiate an IUD within the first 48 hours, the recommendation is that you wait and insert after 28 days. And I think that's important to recognise, because some people are not being offered intrauterine contraception for many months after having their baby. So it can be inserted in those very early stages. Looking at progesterone-only methods, they have no impact on breastfeeding at all, and they are safe. So it's completely fine to initiate your Implanon again when you're on the postnatal ward before you go home. We have discussed the progesterone-only pill, and particularly the newer one in Australia, that's more effective than the old-fashioned progesterone-only pill, so that would also be a great choice. In terms of the starting combined hormonal contraception, you can begin this after 3 weeks if you want to go back on the combined pill, as long as there's not any particularly high venous thromboembolism risk. If you are breastfeeding, though, we would recommend delaying until breastfeeding is established, so for about 6 weeks, and then it can be initiated. And the research we have to date is quite supportive of use of combined hormonal contraception with breastfeeding, and it doesn't seem to affect the ability to breastfeed, the quality or quantity of the breast milk, and isn't associated with any poorer outcomes in the infant.
What about contraception after someone's had a miscarriage or an abortion?
Yes, so it's really important to consider contraception after miscarriage or an abortion, because, of course, not all pregnancies that result in abortion were unplanned, but also not all pregnancies that result in miscarriage were planned or wanted. So essentially, it's good to be getting into the routine of just discussing and offering contraception after any pregnancy loss, obviously in a sensitive manner. Fertility can return very quickly after those pregnancies, so timely contraception is really important. And we know that, for example, after an abortion, if you start contraception within the first 4 days, that it's immediately effective. So we don't need to use any barrier methods for 7 days. So all methods can really be initiated straight away after a miscarriage or an abortion. So, for example, if you were doing a surgical termination, it's completely safe to insert an IUD at that time. You can insert an Implanon at the time of giving mifepristone as well. So I would just fully support immediate initiation of those methods.
Great, thank you.
Much of good contraceptive care comes down ultimately to how we communicate with our women. What makes for a good counselling conversation, and how do we make that conversation clear, inclusive, and non-judgmental, Kirsten?
Yeah, I think it's important to start with patient priorities. So inquiring about where they're at in their reproductive life planning, what their goals, preferences and concerns may be, and to use inclusive, non-judgmental language, respecting different perspectives and backgrounds and reproductive choices. But providing evidence that's clear and balanced, providing both verbal information and written information is often important for people to take away and consider later. And addressing myths and misconceptions. I think that many of us would have encountered people who come in with, ideas about, for example, intrauterine devices that are incorrect, or about the pill that are incorrect. And there's increasing social media saying that hormones are dangerous and So really trying to provide information that reassures the person that, most contraceptive methods, are very safe for most people. Without doubt, the benefits outweigh the risks, and that, it's very important to plan pregnancies as much as possible. So using a contraceptive method that is reliable and is suitable for that person is very important.
I love some myth busting. What common contraception myths do the guidelines help clarify? Kirsten, what do you think?
So there's one, we talk about the meningioma risk with the Depo-Provera, which received quite a lot of publicity in recent years. And I think, the risk has been found, but it's very small. And as I said, with many contraceptive issues, generally the benefits of using a method will outweigh the risks by a long way. So we talked a little bit already about the risk of bone loss and so Depo really is not recommended in very young women in particular. The other kind of myths around cancer risk in particular with the hormonal IUDs, and we know that the hormonal IUDs do confer a small increased risk of breast cancer, but it's very small, and the absolute risk, for example, may translate into 14 additional cases per 10,000 women over a 5-year period. So I think that, again, it's about weighing out risks and benefits. And I think the other concern often with contraceptive methods is about the return of fertility. So we know that the modern IUDs do not impact on fertility, that when you remove them, that your fertility will return straight away. But another concern has been a loss of periods after taking the pill. And again, the studies really show that for most women, their periods will return within 3 months. And studies that have looked at, fertility show that, over 80% will conceive, of those wanting to get pregnant will conceive within 12 months of stopping the pill. Where there is a period of amenorrhea following pill use, it may be associated with, other underlying conditions that have been masked, such as, PCOS or other medical conditions. So, would be worth investigating. But I would reassure women that for the vast majority, that the period returns normally after the pill.
Great. And for you, Catriona, what do you think? Any myth busting you want to throw out from the guidelines?
Well, Kirsten's covered lots of myths there. I think the one I'd like to mention is weight and contraception, because unfortunately it's something that often deters many women, especially young women, from using contraception. And the good thing to know is that the evidence shows there's not really a consistent link between most contraceptive methods and significant weight gain, and that includes the progesterone-only implant. We do know that the depo-medroxyprogesterone acetate, so the Depo-Provera injection, is associated with some weight gain, particularly in women under 18 years who already have a BMI over 30. But with that aside, other methods have not got any causal recognised association with weight gain. And I think the other thing to think about is the impact of weight itself on contraceptive methods. And there used to be this myth, this is really amongst clinicians, that you needed to give people, for example, a double dose of the progesterone-only pill. But we know that that's not correct. So double dosing is not recommended. And regardless of your BMI, you can just take the normal dose of contraception. I think it's just also important when we're discussing contraception and weight just to be really mindful and sensitive about people living in larger bodies who may be subject to stigma and stigmatising behaviour in healthcare, and just to really support them with their contraceptive choices. We know that having a higher BMI is associated with an increased risk of endometrial hyperplasia. So some methods, for example, the Mirena or the levonorgestrel intrauterine device, has got that increased the additional benefit of lowering that risk of endometrial hyperplasia. So in fact, there's some great benefits of using contraception if you are in a larger body.
Great, thank you. So recapping, talking about the levonorgestrel IUD, the Mirena, and cancer risk, we're acknowledging a lower risk of endometrial cancer. But Kirsten, you touched briefly on the controversies recently with breast cancer risk and the Mirena, with a potential tiny increase in breast cancer rates with our Mirena IUD. Is that right?
That's correct, but a hugely positive benefit to reducing endometrial cancer.
Yeah. Okay, thank you for that.
To finish, what are some of the key messages you'd like RANZCOG members and trainees to take away from this guideline, Catriona?
Well, it's critical to reduce barriers to accessing contraception because we want to avoid unintended pregnancies and plan pregnancies when they're suitable and with good timing. So consider things like quick starting, which Kirsten mentioned, and using bridging contraceptive methods when the person's preferred method isn't able to be initiated immediately. And also don't delay initiation of contraception after pregnancy, including after miscarriage and abortion, because we know, for example, that initiating a LARC method after abortion does reduce the chance of another unintended pregnancy in the subsequent period.
How about you, Kirsten?
Well, I would support our guidance and by saying that provision of consistent, clear and evidence-based guidance to healthcare professionals will help facilitate counselling about contraception, and it's a key component of meeting our requirements for universal access to sexual and reproductive health care.
Thanks, Kirsten. For me, one of the key messages was that IUDs can be used in young people who have never had a baby, and that not all of them will need to go under a general anesthetic to have the IUD inserted, although acknowledging that we must address any pain that women will feel or may feel when they have an IUD inserted. Heather, any key messages for you?
I think I'll take away on the IUD message as well, that an IUD essentially could be for any woman who wants it. That's a young woman. That's a woman who only had a baby half an hour ago. That's a woman who's 50 and still wanting to have her contraceptive needs met, and also address some other issues she might have, in particular heavy periods or in her transition to menopause as part of endometrial protection. So yeah, bring on the IUDs, the progesterone releasing IUDs, that is, for women who need them.
Thank you.
And thanks to you, our listeners. You can read the full updated clinical guideline on contraception on the RANZCOG website. We've included the link in the show notes. If you've enjoyed today's episode, please rate, review and subscribe. And while you're at it, please share the podcast with a colleague as well. It's the simplest way to help others find out about Talking O&G. And also log this episode for your CPD. We'll be back soon with more conversations on the issues shaping obstetrics and gynecology across Australia and Aotearoa, New Zealand. Thanks for listening.